Hi, and welcome back. And we're going to continue with the theme of polypectomy. We have a fantastic session coming up where we're going to look at some small, intermediate, and sessile polyps. In fact, we'll bring up the session for you. I've got Lob, who's finishing a procedure, will come and join us in due course. And I've got David with me, Evelyn Decker, and Lynn. We've got online, we've got Mars and Ralph, and we've probably still got Brian in the room because he hasn't left yet, which is perfect. So the session of this, the objects of this session are looking at the smaller lesions, small and intermediate polyps, with a particular focus on the sessile serrated lesions, which I think are problematic. And we've got some real experts in the room here to help deal with the challenges of managing these lesions. We're going to have a session on anticoagulation where I hope I'm going to be a little bit provocative. The quiz question is, according to the 2021 BSG and ESG guideline update, and it is an update, in patients at low thrombotic risk, what is the correct timing to discontinue P2Y12 receptor antagonists before a large AMR?
You can tell John knows the answer to this question.
I'm giving the talk on this, which is worrying. The person who puts their email address in and gets the answer right will get 10 geeks questions.
So can we have Professor Decker's slides, please, on the dysplastic serrated polyp?
So we make it challenging for you. Wow, that's quick.
That is impressive.
Yes, impressive.
Kudos, Aaron, for that.
So indeed, so the question to me that was asked was the importance of the dysplastic serrated polyp. With lecture objectives, what are sessile serrated lesions or sessile serrated polyps, or we will discuss the terminology. Why are the dysplastic ones at such high risk? How to detect those lesions and diagnose, and how to resect? Well, you might be aware that colorectal cancer, this has been already discussed in this meeting previously, is not just one entity. It arises from different mutations during time, and usually we've always been acquainted with the adenoma carcinoma pathway. However, nowadays we know that also the serrated pathway comes into play, and probably let's say an estimated 15 to 30% of colorectal cancers seem to arrive via that pathway, looking at molecular analysis of the cancers. So here's an example of the serrated neoplasia pathway coming from normal epithelium through an SSL acquiring dysplasia, and then finally resulting in cancer. And this is going through a methylated pathway, usually BRAF mutations, it's SIMP high, there might be an MLH1 deficiency, and well, you can see the different molecular hallmarks trying to unravel this pathway. And during that pathway, it's really important to realize that the real precursor lesion is this dysplastic SSL. And that is important because we know that those lesions, once they are dysplastic, probably have a short dwell time towards colorectal cancer. So looking at history data, you can see that at different ages, people have SSLs, so they don't seem that much related to age, but at an older age, they seem to progress further to cancer. And once they have that dysplastic tissue, they might rapidly progress to cancer. Why? Because the regular therapy for SSLs is at the moment, it's cold snaring, maybe if needed, piecemeal EMR. I think it's a great technique, that it's easy, it's quick, and especially the submucosal dye that you can do with colloid or with saline helps you very nicely to delineate the lesion, and you can have nice, clear, sharp edges. And if you do it like that, really taking a normal rim, you probably don't need, but we don't have such good data as we have for adenoma to do the coagulation around, because then you would need a cold snare and a hot snare. So it's always a little bit debatable whether you should do that. I don't think you should, but again, maybe a nice study for somebody to do.